So it's treatment and research updates. Our speakers today are going to be Dr. Yuri Heijden. He is an assistant professor of medicine specializing in adult infectious diseases at Vanderbilt University Medical Center in Nashville, Tennessee in the United States. His primary research involves the study of drug-resistant TB, including collaborative studies in Africa. He is joined by Dr. Karen Bloch. She is an assistant professor of medicine in the Division of Infectious Disease and associate professor of health policy at Vanderbilt. Her research interests include infections of the central nervous system, and she has been an investigator on several emerging infection program studies sponsored by the Centers for Disease Control. I'm now going to pass it along to Dr. Heijden to get us started. Thank you.
And really quickly, can we have Charles, could you start recording the French interpretation, please? Sorry to interrupt.
Well, thank you so much. I'd like to thank the organizers for inviting me to discuss with you COVID-19 treatment and research updates. It's a pleasure to be here with you. My name is Yuri Heijden. I'm an infectious disease physician at Vanderbilt University Medical Center and also have an appointment at the Orem Institute in Johannesburg, South Africa. Next slide, please. I do not have anything to disclose. I do receive research grant support from the National Institutes of Health to Vanderbilt University Medical Center, and I will be discussing off-label therapies today. Next slide, please. What I'd like to do today is start with some general updates about the SARS-CoV-2 global pandemic. I'd like to focus some time discussing REMDESIVIR, and then discuss some other treatment candidates. And finally, I'd like to include some other updates that I think may be relevant and particularly consider some ethical and public health issues. Throughout the talk, I hope to highlight some points that may be of particular interest to those in low and middle income settings. And I just want to go ahead and say that this will not be exhaustive. There are a lot of things that I won't be able to touch on today, and it may be that within a few weeks, a lot of this will be obsolete. Next slide, please. As we all know, what we're talking about is SARS-CoV-2, the cause of COVID-19 as the disease, and it has swept the world with first reported cases at the end of December 2019, and since that time we now have over 4 million confirmed cases throughout the world, including most countries, all continents except for Antarctica. Over 280,000 deaths have been reported worldwide. I've chosen to use this site from Johns Hopkins. They have a coronavirus resource center. It's one among several excellent sites that aggregate data dynamically and provide maps and other graphs to help keep up to date. At the end, I'll have some references that hopefully can be helpful for updated information as well. Next slide. I want to highlight that there are many things that we know, and it's actually quite astounding to look at the number of news releases and publications, as well as preprints, that have to do with COVID-19. In one way, there's too much information, it seems like, and on the other hand, it can be a little bit misleading sometimes because of the quality and reliability of the information that's out there. So I think I really want to point out that it's very important for us to be discerning about the information that we look at. There's also the issue that we think we know, we've learned a lot of things as we've gone along, but there are still large gaps in our knowledge about COVID-19. For instance, relating to epidemiology, we've seen that there are two major types that have been reported, S-type being the first, but L-type now most prevalent and perhaps more aggressive. We've also seen that males tend to have higher risk for severe disease and poor outcomes than females do. But we still don't understand completely the clinical significance or the biological underpinnings or potentially behavioral underpinnings related to these things and how they may impact our treatment efforts. Regarding transmission, we've seen that the primary mode of respiratory secretions that we deal with are in the form of droplets. And we do know that through studies that this virus can linger on surfaces for hours up to days, depending on the surface type. However, there's still quite a bit of controversy regarding aerosolization, to what size droplets the virus actually is expressed in. And we also are still learning quite a bit about the viability of viral particles and virus in respiratory secretions, as well as other types of fluids, such as blood, stool, ocular secretions, and so forth. Another hot topic is immunity. We know that we can detect antibodies that are induced with SARS-CoV-2 infection, but there's still a lot that we don't understand about the relationship of antibody detection to the risk of reinfection. And there's also a big issue regarding the accuracy of the many different products and serologic tests that are being rapidly developed. Next slide, please. Another important factor before we dive into discussing specific treatment is the fact that this global pandemic has certainly disrupted existing health programs and service delivery. This is especially important as we think about other infectious diseases. On the graphic to the right, you can see that just because we're thinking about COVID-19 around the clock, other infectious diseases and non-communicable diseases, they have not gone away or paused. So we're still dealing with service delivery for tuberculosis, HIV, and other chronic diseases that require supply chains and robust health systems in order to deal properly with populations in need. The other aspect to highlight is issues like routine preventive care, vaccinations for children and adults, cancer screening, and other health prevention efforts have been interrupted or disrupted in some way in many places. Stop TB Partnership, as an example, has released a model in which they looked at a 3-month lockdown scenario with a longer socioeconomic recovery period, and they estimated that that would lead to a setback of 5 to 8 years in the fight against tuberculosis. Now that, of course, is a model, but I think it provides an important reminder to us to think about how we're dealing with limited resources and still addressing incredibly important problems in our communities. Next slide, please. So if I had given this lecture a couple of weeks ago, I would have started with a big disclaimer that there are no approved specific treatments. That's changed in the last couple of weeks with the revelations, the release of some interim data about REMDESIVIR, and we'll talk more specifically about that. But I do want to mention, just as a reminder to all of us, not to forget the basics. So first of all, that has to do with being consistent in our public health messaging and thinking about infection control and prevention in healthcare settings. So just because we're pursuing targeted therapies, we should not forget about how we are providing a consistent message to those around us. In the infographic to the right from the US CDC, you can see reminders for hand hygiene, for staying at home when feeling ill, and for physical distancing efforts. As another example, we should not abandon principles of evidence-based care, and that applies in the midst of an urgent and emergent pandemic where we're rushing to try to find therapies. We still should not forget important therapies that have been developed and tested in interventional trials throughout the years. As an example, in the intensive care unit, there are care bundles, ventilator settings, and other manners of care that have been tested over time. And these are discussed in a nice article stressing the importance of not abandoning data that have developed over time in the article that's referenced on this slide. Next slide, please. This is a nice graphic just to help us orient to some treatment targets as SARS-CoV-2 enters the host cell and goes through multiple steps for replication. The steps that I'll focus on most today with this discussion of treatment is REMDESIVIR. I'll talk about chloroquine and hydroxychloroquine, and spend some time on lopinavir, ritonavir. I'll touch briefly on some of the immune modulators, and we'll mention some other treatments that are being pursued. Next slide. This is a graphic that helps us remember and orient to the disease process. And as we know, most people will either have very mild symptoms or may not even develop symptoms. But for those who develop sickness that requires hospitalization or is even more severe, requiring intensive care, there seems to be a specific time course that may be followed. So initially we think about the early stages of infection where this is primarily driven through viral response. Then there can be clinical worsening after what may be apparently a clinical improvement. We see respiratory symptoms become more severe during this pulmonary phase. And then as people may develop ARDS, shock, or cardiac failure, or even death, this seems to occur in the presence of a robust host inflammatory response phase. Sometimes people refer to this as cytokine storm, and there's clearly a lot of work being done to try to understand how we can intervene at different points along this spectrum. As you can see from the bottom rows that discuss potential therapies, there are a lot of trials going on as we try to understand at what point some of these interventions may be most and best suited. Next slide, please. Certainly popular in the news media and in a lot of scientific announcements is REMDESIVIR. So I'd like to spend a bit of time discussing REMDESIVIR as a treatment. It's a prodrug that's metabolized to an adenosine nucleotide analog. This inhibits viral RNA-dependent RNA polymerase. And this compound has shown efficacy against SARS-CoV-1, MERS-CoV, Ebola virus in vitro and animal studies, and has also shown efficacy against SARS-CoV-2 in vitro. Next slide. So April 29th was a busy day regarding announcements for REMDESIVIR, and I'm going to walk through a few of them. So this one that I'll talk about first was published in The Lancet, and this is a study from the Hubei province in China, and this was a multi-center randomized double-blinded placebo-controlled trial that looked at the use of 10 days of REMDESIVIR compared to control and placebo, and the primary outcome was time to clinical improvement, where clinical improvement was defined on a 6-point ordinal scale. And as you can see on the graph to the right, you can see that REMDESIVIR and control, the rows along the bottom show the number of patients. And so patients were randomized in a 2-to-1 ratio. And this graph shows the intention to treat analysis. And what you can see is the time since the start of study against the cumulative improvement rate. And you can see that they show a hazard ratio of 1.23 with a non-significant p-value. And so there was no difference in remdesivir compared to control in terms of time to clinical improvement. When they looked at a sub-analysis and they looked at those who had a symptom duration of less than or equal to 10 days before starting remdesivir or placebo, they found a higher hazard ratio with a confidence interval you can see there. It's not significant, but it indicated a signal that perhaps using the treatment earlier there may be a signal there. Now, this study was stopped early, and this was attributed to control of the outbreak in Wuhan, in the Wuhan province. In Wuhan, the Hubei province. And the authors concluded that, that these findings pointed to the need for larger studies. So next slide, please. On the same day, the drug company Gilead announced some initial results from their SIMPLE trial. This is a phase 3 open label study where they compared 5 days of remdesivir to 10 days of remdesivir. So this was not a study looking at the overall impact of remdesivir compared to no treatment, but really was looking to see if there was a difference in the duration of treatment in terms of outcomes among hospitalized patients with severe disease. And as you can see from this table that was released, if you look at the first column of data, that shows the 5-day remdesivir results, and the next column shows 10-day remdesivir results. And there were no differences in the outcomes that they studied. The importance here, I think, is that depending on the patient population used, if we can, and ultimately, if the use of remdesivir bears out, then it's important to think about being able to use a shorter course, and this could save resources for additional patients. Next slide, please. The last announcements from that same day that I'll mention was one that got a lot of press attention, and that was a notification from the National Institutes of Health that showed an interim analysis of the ACTT trial, an adaptive treatment trial. At this part, looking at randomized placebo-controlled trial of remdesivir. And this was a large study, or at least the interim analysis has a large number of patients, over 1,000 compared to the other announcements we looked at. Included multiple sites, mostly in the US, but also from countries in Europe and Asia. And it shows a median time to recovery of 11 days versus 15 days with placebo. This is a significantly faster time of recovery. And it was also pointed out that though it was not significant, the mortality rate for those receiving remdesivir was lower than those who received placebo. And so, though not significant, there was indication that perhaps there's a signal there to look at further. So, next slide, please. This announcement led to the U.S. Food and Drug Administration to issue an emergency use authorization shortly after, on the 1st of May. And what they have done is provided the means for providers to prescribe remdesivir outside of clinical trial settings. So this is for remdesivir for the treatment of suspected or laboratory confirmed COVID-19 in adults and children who are hospitalized with severe disease. And they define severe disease as any of the 4 following criteria that you can see listed on the slide. Next slide, please. I've shown you this here, and there's also a reference on this slide and at the end regarding an extensive document, this EUA, that shows a lot of the details about administration of remdesivir, I wanted to show this box which demonstrates there are two distinctions in terms of prescriptions. First is based on weight, so weight greater than or equal to 40 kilograms versus weight less than 40 kilograms. And then the other distinction is whether or not patients are on ventilatory support or ECMO compared to those who do not require mechanical ventilation or ECMO. And the difference really is in the duration of treatment that's recommended. For those with more severe disease, as evidenced by being on mechanical ventilation or ECMO, it's 10 days of treatment. And those who do not require that support, the recommendation is for 5 days of treatment, though an option to extend treatment up to a total of 10 days. I think some other important points that I wanted to mention are, first of all, caution is recommended in people who are pregnant or who have evidence of hepatic impairment, and the medicine is not recommended in those who have a glomerular filtration rate of less than 30 milliliters per minute. The other thing I think may be relevant is considering the capacity of healthcare settings to, in the procurement, but also maintaining the medication. So it's delivered as a powder that needs to be reconstituted with sterile water and saline. It needs to be done in conditions where an aseptic technique can be guaranteed because there's no preservative or bacteriostatic agent. And once reconstituted, the solution needs to be administered intravenously immediately. It can be stored up to what's considered room air for 4 hours, and if not used within 4 hours, it can be stored up to 24 hours in a refrigerator conditions, as you can see. But it really is recommended to be used immediately. And in this authorization, providers must provide a fact sheet that goes along with remdesivir to patients and their caregivers. Next slide, please. An important issue to consider are potential adverse effects. People can have an infusion reaction when receiving remdesivir. Some of the more common side effects that can be described are nausea, and liver enzyme elevation has been noted. Now, it should be noted that in reports that we see about COVID-19 patients, some of them without being on remdesivir have also been noted to have liver enzyme elevation. So it may be difficult to distinguish the effect from remdesivir, but regardless, the recommendations are that liver tests should be checked at baseline and then daily during the administration of remdesivir. And then there are guidelines as to when it should not be started, and that's if the ALT is greater than or equal to 5 times the upper limit of normal. And if ALT rises during treatment up to that level or above, the medicine should be discontinued, though this does appear to be reversible largely. Also, if there are signs of liver damage or inflammation through markers that you can see on the slide, it should be discontinued. There also should be mandatory reporting of adverse effects and medication errors. We'll have opportunity to discuss remdesivir more if there are additional questions, but at this time I'll move on to hydroxychloroquine and chloroquine on the next slide, please. So these are aminoquinolines. They've been around for a while for the treatment of malaria and as immune modulators in conditions such as lupus and rheumatoid arthritis. There are proposed possible antiviral mechanisms for these drugs, many of which center around the alteration of pH in the endosome and the phagolysosome fusion step. Next slide, please. There have been lots of small studies that have come out. Most of them have been small so far, with varying results. I'm not going to summarize all of them, but I've mentioned or have noted just a few here that correspond to the timeline in terms of national notice we've received in the US. So initially, on the 20th of March was the release of a small study. It was open label, was not randomized, that looked at the use of hydroxychloroquine with or without azithromycin. Again, it was a study with 36 participants, so relatively small, and the endpoint looked at day 6 viral load, and investigators noted that there was a reduction in viral load among those who received hydroxychloroquine. So there was some attention with this and the results of other studies, and it led to an emergency authorization from the FDA on the 28th of March. Then about a month later, there was the FDA caution against use, and there were several studies that came up. One of those was one that I've noted here from Brazil that was a phase 2B randomized clinical trial that looked at a high dose of chloroquine compared to lower dose of chloroquine. It should be noted that azithromycin was used for the treatment of individuals in both arms, and many patients were also receiving oseltamivir. This study was stopped at a safety review board meeting after review, and found that the group with the higher dose of chloroquine had a signal for higher mortality and QT interval prolongation. So this trial was stopped and raised concerns about this potential that was already known about the potential for prolonged QT interval, but now this signal came through early in this trial. And then after the caution against use, most recently on the 7th of May, a larger study was published in the New England Journal of Medicine, and this was an observational study that looked at hydroxychloroquine compared to those who had not received hydroxychloroquine, and they did not find any difference in intubation or death as an endpoint. So I think that the story of hydroxychloroquine and chloroquine will continue to unfold. I definitely think that the enthusiasm that was first demonstrated has been dampened, largely out of concern for these adverse effects, which are not trivial and should certainly be kept in mind. I think an important note also is the potential for drug-drug interactions, particularly as we think about low and middle income settings that may have high burdens of tuberculosis, HIV, and I think it will be important to clarify the potential for drug-drug interactions with antiretrovirals, and especially drug-resistant TB drugs that may also have the potential for QT interval prolongation. Next slide, please. Going next to lopinavir-ritonavir, an HIV protease inhibitor, I'd like to present some of the one study that came out that looked at the comparison of lopinavir-ritonavir for 14 days compared to standard care among hospitalized patients who had to meet criteria for low oxygen saturation. And the primary outcome that was looked at was time to clinical improvement. You can see here in the graphic that both groups had about 100 patients each, and the hazard ratio was found to be 1.31. This was not found to be significant, however, and I think that the response to this article was in many of the news media outlets was really that this study suggested really no difference, and that many people had diminished enthusiasm for lopinavir-ritonavir after this. I think it's notable, however, that there were multiple letters to the editor at the New England Journal, and some of the concerns raised were that this study may have been underpowered for the endpoint described. Also, it was noted that individuals were randomized late into the course, so 13 days on average, or a median time to randomization. And also, many people looking at secondary analyses found that there were signals that suggested that lopinavir ritonavir may not, or it may be beneficial. And so I think this is also still an unfolding story. There are certainly still trials going on looking at the use of lopinavir ritonavir, and certainly at the outset, it's been one that's held promise, particularly in settings where lopinavir ritonavir has previously been used as an antiretroviral in HIV treatment programs, and may still be around as second-line or lower treatment option for HIV. So I think we will need to pay attention to how this story continues to unfold as well. Next slide, please. Then, very recently, there was a study that's generated some buzz, and that's this triple antiviral combination that also looks at the use of lopinavir ritonavir, this time in combination with ribavirin, as well as every other day dosing with a total of 3 doses of interferon beta 1b. This group of antivirals was compared to 14 days of lopinavir ritonavir alone. And the results that have just come out suggest that the combination group had a shorter median time from treatment to negative nasopharyngeal swab. You can see 7 days versus 12 days. So 7 days shorter time for the combination group versus 12 days for the lopinavir ritonavir group alone. I think that some discussion will continue in the days that follow regarding the endpoint here, the negative nasopharyngeal swab. There's some discussion about that as we see patients clinically in the hospital. Some patients tend to have persistent positivity in nasopharyngeal swabs that may be evident in different age groups or other populations. That still remains to be seen. But I think taken at face value, the implications of this study may be that early treatment with the triple antiviral combination may shorten duration of viral shedding and by implication alleviate symptoms and help facilitate discharge of patients with mild to moderate COVID-19. Again, this has received a lot of attention. I think there will likely be some follow-up to help guide us after these results have come out. Next slide, please. I'm going to briefly mention immune modulators. These are a group of medicines that have been proposed to help in the setting of this robust immune response that we mentioned earlier, the cytokine storm. And you can see some of the targets that are being investigated. There are anecdotal reports of their use with good outcomes, and there's a long list that's being added to frequently, it seems like, of compounds and medications that may be looked at and that are currently being studied. I think it's worth mentioning, particularly in relation to low and middle income countries, that there's an ongoing study with colchicine. And the reason I mention that is just that it's likely that if this does turn out to have a role in the treatment of COVID-19, it may be much more widely available already throughout the world as a repurposed treatment. And it will likely be much less expensive than most of the other drugs that you see listed on this slide. Next slide, please. Another area of attention has been convalescent plasma. The idea here is that patients who have had COVID-19 have generated an antibody response that then, through passive antibody transfer, is introduced into patients who have COVID-19. And this technique has been used before in H1N1 influenza, MERS, Ebola, and we've already seen through some of those previous viruses that we've seen reduced viral load, serum cytokine response, and reduction in mortality. So there was a case series that's referenced here of 5 severely ill COVID-19 patients in China who had improvement. And I think as ongoing studies will reveal how this really bears out. We'll need larger numbers in well-conducted studies to demonstrate this. This may be a viable option in terms of some settings where the necessary equipment is in place for convalescent plasma transfer. Next slide, please. Just to mention some other compounds that may be on the horizon. At the end of April, there was a publication that came out showing two compounds that were related, N-hydroxycytidine, NHC, and its prodrug. And the reason I mentioned these is first of all that these appear to be, they may be orally bioavailable, so they may be an option that can be used orally against a number of different coronaviruses and other viruses. So there may be a broad antiviral effect that could be used and potentially even as treatment or prevention. Again, this is early stages for these compounds, just as there are for many other compounds. Human trials are pending, and we'll show if this bears fruit. Next slide, please. There are a host of other unproven considerations, though you may have heard of many of these. They're certainly around in different reports. Nitazoxanide, ivermectin. There's been a lot of discussion about vitamin C, vitamin D, and zinc, MPRO inhibitors, and then I've put vaccines on this list as well, just because they've received a lot of attention. And you can see on the graphic to the right that as of the publication in April, there are a number of different vaccine candidates at different stages of development. And I think we'll have to follow the unfolding story for all of these different candidates. Next slide, please. Just want to mention, as we think about words of caution, that this enters into the discussion where there's some back and forth about the compassionate use of drugs that aren't proven yet, or reserving them for well-conducted clinical trials. There are benefits and risks to consider, and the benefits are that those who receive these medications may have evidence of decreased viral activity, decreased disease progression, cure is what we hope for, of course, and potentially even decreased transmission. But it's important to note that there are risks with those, with an approach, including unknown adverse effects. Costs need to be considered, and then the idea that it may be, if we use these before we have well-conducted study results, we may hide the true efficacy of treatment. Could also lead to delays in defining the most appropriate care for future patients in settings of future outbreaks. There are also risks that are that we've seen even with the hydroxychloroquine study of stockpiling medications to the degree that those who need the medications for other indications cannot access them. Next slide, please. Another word of caution in this article that is referenced here, and I'll just read from the abstract: indiscriminate promotion and widespread use, in this case of chloroquine, hydroxychloroquine, have led to extensive shortages, self-treatment, and fatal overdoses. So I think it's just important to think about what we're messaging in terms of a public health approach and within our health systems. Next slide, please. And this is not just in Africa or in resource-limited settings. This occurs worldwide. And although headlines like these are sensational that I've posted, they do point to this fact that we need to consider how we're messaging treatments that are under investigation. Next slide, please. Some ethical considerations. We could spend an entire lecture on this, but I just want to mention a few points. It's very important to consider equity of access. That's important within communities where disparities that already exist may be amplified. It's also important in a global context as we think about powerful nations that have the ability to leverage their power to access supplies and interventions where others may not be able to. I think there's an important point about how we conduct research, and that we do conduct research in low and middle income settings, and that interventions should be considered the context where we're looking at interventions that will likely be affordable, adaptable, and scalable in the populations in need. Next slide, please. Just a couple of quick additional updates as in closing. This is a graphic that's shown from a study in from skilled nursing facility where if you look at the x-axis at 0, these are days from first evidence of fever, cough, and shortness of breath. And if you work backwards from 0, you see that up to 6 days before individuals were identified as having those symptoms, there were positive cultures already present for SARS-CoV-2. This goes along with several other reports that have shown a substantial pre-symptomatic period may be present. And I think that's really important to think about community transmission in all of our settings. Next slide, please. I think this has relevance, next slide, please, and relates to how we might intervene in the absence of widespread available treatments. So this is one policy. Again, there are many that need to be decided at local levels, or at least regional levels, but this is one example of modeling exercise that looked at uptake of masking after a lockdown situation was relaxed. And if you see the red bar at the bottom shows a decreased incidence in the population expected with 80% uptake of masking in the population, which is even different if only half, 50% mask. And the gray bar graph with the large rise shows if only social distancing occurs after a strict lockdown period. Next graph, please. Next slide. This is from the same model, and this shows deaths in millions on the y-axis and days on the x-axis. And you can see those same categories. There's quite a substantial difference in the uptake of masking in the population. Of course, keep in mind these are models. This one has not been published, but I think what's really important is just as we think about what are the interventions that are possible, we need to carefully consider the data that are out there and what may be done without access to medications. Next slide, please. So in summary, I want just to remind us all that we should not abandon the basics that we know about for prevention and treatment. There are emerging therapies, both new and repurposed medications that are plausible, but many have unproven efficacy against SARS-CoV-2. We do need well-designed studies to continue. There are many out there, and we eagerly await additional results. We need discernment when we evaluate the results of those studies. We should consider potential consequences of unproven therapies, and I think it will take thoughtful leadership and wisdom to consider the ethical distribution of new treatments and how we develop public health policy. Next slide, please. I have a couple of slides of references. There are references throughout the slides, which will be available afterwards, and I have a few categories that hopefully will be helpful for your reference. Next slide, please. These are additional, and next slide, please. I'd just like to finish by thanking you for the opportunity to speak, but also want to thank all of you, my colleagues in settings, many of you on the front lines in a very difficult time. So thank you for your hard work and your dedication and care of patients around the world.
Thank you so much, Dr. Heijden, for that really interesting presentation. We're now going to move directly into questions and answers. Just in the noticing the time, we have about 15 minutes left in the call. Dr. Matt Kynes is going to be fielding the Q&A portion. Again, please submit. I see some people have been putting the questions in the chat. Please continue to submit questions in the chat, and we will address them, as well as the questions from pre-registration. Dr. Matt Kynes is an assistant professor of pediatric anesthesiology at Vanderbilt University Medical Center, where he also directs global health training programs for anesthesiology residents and fellows and is involved in research and education for anesthesia providers in East Africa. Dr. Kynes, I'll pass it over to you.
Thank you very much. And I believe Dr. Bloch is on the call as well and will be able to chime in with some answers. She's a colleague of Dr. Vanderheiden's in infectious diseases. And actually, there have been a couple of questions, Dr. Bloch, about adjuncts with hydroxychloroquine. And one question about using zinc as an adjunct, and then another question about the common prescription of azithromycin for COVID patients. Could you comment about both of those treatments for us? And if you're not able to come on,
sorry.
Dr. Vanderheiden, sir, go ahead.
Hey, this is Karen, and I apologize. I've been having some Zoom issues, so I hope you guys can hear me. You know, I think that's a good question. There has been a lot of interest in use of supplements. I think zinc is one that's gotten some attention. I think others include various vitamins. I think vitamin C has been a popular supposition that it may have some efficacy. I think right now we really don't have a lot of data to support these supplements being used either in conjunction with other medications or alone. And so I think we're sort of in this data-free zone right now where we're waiting for studies to come out that may help support these. But for now, I think that the recommendations, at least at our institution and in the United States, are not to use zinc either as a supplement for other medications or as a standalone for therapy.
Good.
Yeah, I agree. And I would also say that as we wait, there are studies ongoing looking at the use of these. I do think that one issue that's come up is the issue of how some of these economic shutdowns have led to food insecurity, and malnutrition, of course, is a big concern. So I think setting in the right context as we think about nutritional deficiencies, there may be roles for, I think in general, the relationship between malnutrition and immunity is one that's has been explored and is continuing to be explored. And there may be appropriate contexts for supplementation in the existence where food insecurity and malnutrition abound. But I agree completely with Dr. Bloch that as standalone therapies, these have not been proven. And the other concern, of course, is overdosing with some of these. So there are, there may be negative consequences, we know, to hyper or very high doses of some of these compounds. So we need to be aware that occasionally people may think that if some is good, a lot is better, and that is certainly not always the case. So we need to be cautious about that as well while we wait for additional data.
How about the use of azithromycin? It's commonly prescribed, the rationale and efficacy for that treatment.
You know, I think there has been a lot of enthusiasm for it. We know for other infectious diseases, not only does azithromycin have a direct antimicrobial effect, it has an anti-inflammatory effect. And so I think it's appealing for both of those reasons. I think the main concern of it is similar to that seen with chloroquine and hydroxychloroquine, which is there are a lot of toxicities with the medication. And most of the studies have been looking at use of azithromycin in combination with one of those two drugs. And so we're amplifying some of these negative effects, particularly the side effect of QT prolongation. And I think that is a big concern. I think when Yuri showed that really nice slide looking at some of the studies with hydroxychloroquine or chloroquine that have been stopped because of adverse effects, many of those were combinations with azithromycin. And I think that's led many of us to be extremely cautious about that combination.
Thank you. Couple of questions about asymptomatic patients. And Dr. Vanderheiden, you mentioned that there's a pre-symptomatic phase. Could there be any indication for using drug treatments to prevent progression to a symptomatic phase in high-risk patients, or to prevent transmission?
I can jump in on that one. Yes, that would be wonderful if we could have prophylactic medication to prevent progression from any step. The initial would be from a pre-symptomatic or an asymptomatic phase to more complicated infection or disease process. I think the considerations are that we need to consider as we think about that is we have general epidemiologic predictors. We know that patients who are older and have comorbidities are at higher risk for severe COVID-19 disease, but we still don't know who would benefit the most at the outset. It could be that we develop risk stratification options for prophylaxis or prevention, or in the case of those who may test positive before they develop symptoms. But I think the bar is going to be really high for the medications that are used because of the fact that many of those may never, even if we had not intervened, would not have developed severe disease. And so then you're introducing a medication, and if it has high rates of potential adverse effects, I think that would be, people would be very cautious about using that. So it's a tricky spot, but yes, I think there are a lot of medications that are being considered for that, and we'll have to see how that develops. You know, certain populations, again, high risk groups, frontline providers, healthcare providers, may be appropriate for receiving preventive or strategies like that. Those are under investigation.
We have a question about using aspirin for COVID patients as an adjunct therapy. Do either of you have a comment about that?
So I will jump in and say there had been some concerns early on about use of nonsteroidal anti-inflammatory agents with a theoretic risk that might facilitate viral entry into cells. I think that has not been shown definitively, and I think the jury is still out on that. I think many healthcare providers have opted to be cautious with the use of NSAIDs and by extension aspirin without great data showing that it has a deleterious effect. But I think many providers would use Tylenol or similar compound as first line. The challenge, of course, is with some of these drugs, we are seeing liver toxicity, and so then Tylenol may not be the optimal treatment. So I am not familiar with aspirin per se, but I will say that NSAIDs, again, probably could be used cautiously, but if there are other alternatives for antipyretics, they may be first line.
And if I may jump in, one other angle that I agree completely with Dr. Bloch. Another angle that this has been brought up is just the high rates of thrombotic and coagulant complications and coagulopathy that we tend to see with oftentimes in severe COVID-19, and also some concerns that it may even be occurring in people with milder disease. And this is still an area of investigation. Certainly in hospitalized patients, we're starting to see more evidence for the use of anticoagulants appropriately. But the broader use of aspirin as an antiplatelet agent has been theorized, but we don't have data to know if that would in any way be helpful to prevent some of these thrombotic complications. So I think that's an area that needs study and needs attention, but we don't have enough data to say anything for or against it at this point with that in that regard.
I'm going to jump in real quick because I think that's a great side point that I didn't touch on, and I agree 100% that for anticoagulation purposes, using sort of routine, whether it's low molecular weight heparin or aspirin or whatever modalities available might have a role, particularly in hospitalized patients. The other thing I wanted to say, which I neglected to in my initial answer, is if you have patients who are already on aspirin for other reasons, cardiovascular or otherwise, or who are on nonsteroidal anti-inflammatories for other reasons, the recommendation is not to stop these. Rather, it's just to be cautious about starting.
Thank you very much. A question, I think this is an important issue about immunity after infection. And I know we don't have the data right now, but how or when might we know if a patient who has survived an episode with COVID has any level of long-lasting immunity to the disease?
Boy, that is the hot question right now. So thank you for bringing that up. That's a wonderful question, and we all are wondering that same thing. The good news is that the infection appears to be very immunogenic, that most individuals, particularly who've had symptomatic infection, develop antibodies. But I think one of the big questions is whether these are protective, probably in the short term is a thought, but for what duration of time? And so I think that as we get testing capabilities to measure antibodies, I think the lingering question is, what do we do with that information? Because I think as of now, we don't have definitive data to suggest how long those antibodies give protection. And I think the analogy is other coronaviruses. So for instance, some of the other viruses in this same family cause the common cold. And unfortunately, individuals are susceptible even after having had one coronavirus. So I think we have to have some caution just based on our history with other viruses in this family.
Thank you. We are approaching the end of our time, but I do want to say that there will be an opportunity to continue the discussion on our WhatsApp group afterwards. So thank you both for your help and presentation today. Thank you for all of our participants, and I'll hand it back over to Monica to close out our session.
Great. Thank you so much, Dr. Kynes, Dr. Bloch, and Dr. Heijden. This was a wonderful session. Thank you very much. Again, a lot of unanswered questions because we've run out of time, but we will continue this conversation, as Dr. Kynes mentioned, through the WhatsApp group. I would like to just thank the Vanderbilt team, the Vanderbilt University Medical Center, the Vanderbilt Institute for Global Health, and GE Foundation for helping make all of this possible. I would just like to pass it along to my colleague Claire to explain the WhatsApp chat group function.
Thanks, Monica. Yes, as was mentioned, we have a WhatsApp group that's available. You can submit your questions here in the group, and we have several faculty members from Vanderbilt University Medical Center who are in the group who can help answer your questions. And you can join the group by scanning this QR code with your cell phone. We'll also send out a link to your email if we have your email address. And if you have any trouble, any difficulty connecting with our WhatsApp group, you can email us at echo@assistantinternational.org. Thanks.